everyone, if you could take your seats, we'll get going so we can start on time. Good evening, everyone. Welcome to the Café Scientifique put on by the Canadian Institutes of Health Research. And tonight's discussion will be, is obesity a disease? And we're going to begin, before I even introduce myself, you've got a pad of paper on your table. There should be pens there. I'd like you to answer this question. Yes, no, or unsure. Just write it, fold over the paper so it's confidential, and Zach or Travis will come around with a little bag. You can dump it in, be completely confidential, and I'll get another manuscript, so it'll be great. Just take a minute. Okay, so everyone's engaged now. Before I begin and sort of go through the program, just a couple housekeeping announcements. First, this session is being videotaped. If you don't want to be a part of that, I would suggest that when we get to the Q&A section, that you hold your question until after the main event is over and speak to the panelists on your own over coffee or something, because the cameraman here, I assume, will be going to this microphone, which will be down in the audience at that time. So if you have a problem with that, just stay away from the mic. There's also a petition at the back somewhere encouraging debate on healthy active living in the House of Commons. The exact motion is there. If you're interested in signing it, it's at the back. Please do. And finally, also on the tables is an evaluation form. Where is that exactly? Okay, so they should be like that. It's essential that you fill those out. It's important for the Canadian Institutes of Health Research to get that information. So please, as we go along, if you feel comfortable filling it out, or certainly at the end. Okay? And so we're ready to go. My name is Mark Tremblay. I'm the Director of the Healthy Active Living and Obesity Research Group at the Children's Hospital of Eastern Ontario Research Institute. I'm also the Chief Scientific Officer of Active Healthy Kids Canada and Professor of Pediatrics at the University of Ottawa. And I have the privilege of moderating the session this evening and trying to facilitate and encourage open and frank discussion. The speakers, who I'll give you their bio a little bit later, is Dr. Arya Sharma from the University of Alberta and Jackie Jingra from the Ryerson University. And I've taken the liberty of sort of giving a hint as to their orientation with respect to this topic. I want to begin by thanking the Canadian Institutes of Health Research for the support that allowed the speakers to be brought in for this event. So thank you very much. I think there's a CHR representative here. I'd like to thank the Canadian Obesity Network for supporting and promoting the event, as did the Healthy Active Living and Obesity Research Group. Many people are here. And a particular thanks to the Canadian Obesity Network student and new professional group from Ottawa. Pictures are up there in the corner, and a special thanks to Travis Saunders and Zach Ferraro for really spearheading this and making it happen, getting the application in, getting the funding in place, and making tonight happen. So thanks very much, guys. This wouldn't have happened without them. This is the agenda for this evening. It looks rather detailed and complicated, but hopefully it's going to be rather casual and fun, possibly inflammatory. I'm going to begin with just a few comments, just setting the stage, hopefully neutrally. And then we're going to have basically 3 30-minute discussions. The first on the health impact of obesity, the second on the medicalization of obesity, and the third on whether obesity should be seen as a disease. Each will follow the same sort of format. One speaker will go for about 7 minutes. The other speaker will speak for 7 minutes. They'll have an opportunity to comment on what one another said, and then we'll open it to the floor for discussion. Then we'll go to the next thing. Okay? At the end of it all, we'll have the results of the survey to see where you stood, at least at the beginning of the night. So just as a brief background, I don't know how well you can see this, and the numbers for all of these are going to be really small for people at the back. But this is really just to point out, and I'm going to use a similar theme going from the world to Canada to Ontario to Ottawa, kind of zooming in on our own issue. But the point of this slide, this is the WHO global map on the prevalence of obesity worldwide. You're not going to be able to see, but wherever you see sort of pink and reddish colors, suggest that those countries have between 10 and 30 or even 40% adult obesity. The gray is missing data. All right? So the point is that in the developed world, this is a very prevalent problem. Zoning in on Canada, more than 1 in 4 adults in Canada are obese based on measured height and weight from the recent Canadian Health Measures Survey. When based on self-reported data, the results are substantially lower, but we are able, with the self-reported data, to have better geographic resolution, and it shows substantial variation across the country, as seen here. Varies from 5.3% to nearly 36% in health regions across the country. Very crudely, there's a west to east gradient with higher proportions in the east than the west. Obesity tends to increase with age until age 65 at least. And whether males or females it's more prevalent is open to debate, and really depends a little bit on where you're talking, what populations you're talking, different immigrant groups, different socioeconomic groups. In terms of children and youth, 8.6% of Canadian kids, as measured from the Canadian Health Survey, are obese. 6.3% of age 2 to 5 from the 2004 data are obese. There's different systems, and it's complicated when you're looking at obesity rates in children. However, what is uniform is that regardless of what cut points, what system, self-report, or direct measure, there's an increase over time in childhood obesity. Someone may debate whether or not just in the last year or two it's plateaued, but generally across the last generation, there's been a doubling to a tripling, depending on which age group you use. Obesity tends to be more prevalent in boys than in girls. So that's Canada. If we look at Ontario, here's the most recent map. So this is like the WHO one that I showed earlier. The red is higher prevalence rates than the yellowish ones that you see down in southern Ontario. But these all start in the mid-40 percentile. So the prevalence of, and this is overweight or obesity, the prevalences are in the mid-40s to the mid-50s. Note the date here, this is 2000. We go ahead a decade, much more red, less yellow. So in virtually all areas of the province, the prevalence of obesity is on the rise. Got Ottawa pointed out there. It does tend to be slightly lower than the provincial average, not a lot. Still, with about half of our population self-reporting being overweight or obese. Now I'm going to take a little bit of liberty to show some new data from work that I've been involved in. So that's showing you the trends in obesity, the prevalence in obesity based on, most of the time, self-reported body mass index, okay, which is our population level way to look at this. However, there's pretty good evidence from Canada, and I think from other countries as well, that there's an adiposity metamorphosis going on here. That for a given body weight, we're fatter now than we used to be. So if you're a 175-pound male in 1960 and a 175-pound male today, odds are much more of you is fat, even though you're both the same weight today than in the past. And this paper that was just published this month, I think, concludes by saying that present-day Canadians have higher waist circumference and skin fold thickness values for a given BMI than Canadians in the past. So in other words, a BMI in the past is not necessarily equal to a BMI today. And just to show you an example, here's the distribution of the adult population in Canada aged 20 to 69 years. Their waist circumferences, and I don't know if you can see from back there, but there's 4 lines on this graph. And as they progressively skew to your right, they get closer in time. So the first line, the furthest to the left, is from 1981, then 1988, then 1990, then 2007, 2009. And you can see this rather substantial distribution shift, that the population has a higher waist circumference. Now you're going to say, of course, you just told me that the trends in the prevalence of obesity has gone up, so it makes sense that the waist circumferences have gone up. Except that, when you isolate it by BMI category, the same pattern exists. So again, you're not going to be able to see this, but just pick any one. Pick the top right one. Okay, men are on the left, women are on the right, but similar pattern exists all the way through. And these panels, as you go down, are normal weight, overweight, and obesity. All right? And what you're seeing in those 2 curves, the darker colored curve is 1981, the lighter colored curve is 2007, 2009. And so you can again see this shifting of the entire distribution, and the shaded areas to the right, to the far right, are high risk, and then moderate risk, and then the white area is no risk. So you can see that as the distribution shifts, there's more people at increased health risk within a BMI category. So that top one is a normal, healthy BMI. Okay? BMI is less than 25. So even within that, we're becoming more fat. And so you could say, well, again, so what? Well, the so what is that we then went and looked from the Canadian Health Measures Survey at cardiometabolic disease risk factors within BMI categories across things like waist circumference, waist to hip ratio, waist to height ratio. And indeed, and again, you're not going to be able to read this, but basically what we show is that within the normal or overweight BMI categories, that there is a gradient based on waist circumference, waist to hip ratio, and waist to height ratio, such that within a healthy BMI category or within the overweight category, there's this gradient that if you have a higher waist circumference, higher waist to hip ratio, or higher waist to height ratio, that you're at increased risk. And we were looking at fasting glucose, HDL cholesterol, triglycerides, systolic and diastolic blood pressure. Okay. So, what's going on in the country as a result of this? And again, I'll sort of start bigger and go smaller. Well, at the world level, in just September, the UN made a declaration committing to a reduction in non-communicable diseases around the world. So on a global level, since 2004, the World Health Organization has identified a reduction in obesity as a priority. Within Canada, since September 2010 is the latest time it was declared that this is a priority, they released this document, Curbing Childhood Obesity, a federal, provincial, and territorial framework for action to promote healthy weights. And what the framework focuses on is 3 integrated strategies: making childhood overweight and obesity a collective priority for action among multiple government departments and sectors of Canadian society; coordinating efforts focused on 3 priority areas: supportive environments, early action, prevention, there's a prevention companion document that goes along with this, and nutritious foods. And finally, a commitment to measuring and reporting on the collective progress related to this. So this was at the ministers' meetings in Newfoundland in September 2010. And it has a vision of Canada as a country that creates and maintains the conditions for healthy weights so that children can have the healthiest possible lives. Some of you may have participated in this. This was the web page. It was a national consultation open to anybody. Could be a healthcare practitioner, could be Joe Public. And they asked you for your advice as to what should be done. What should the federal government do? What should the various stakeholders do to try and address this problem? Or even, is this a problem? Zoning in a little bit, just a couple weeks ago, Ontario set up a panel to tackle childhood obesity. Some of you might have read about that in the news. And so Ontario is looking at this same issue. And 3 or 4 weeks ago, the Ottawa Board of Health announced its HEAL strategy, healthy eating and active living strategy. So same thing, focusing on this particular issue. So you see the priority at the global level, at the national level, at the provincial level, at the regional level, all within the last year. So, to summarize my introductory comments, obesity and excess adiposity are common and rising. I don't think there's any doubt about that. The rates are rising greatest in developing countries where the prevalence is still low. The world, Canada, Ontario, Ottawa have identified a reduction in obesity as a priority. And some questions that our speakers will I think, hint at or get at tonight is the obesity epidemic the result of sloth and gluttony, laziness, and too much eating? Or is it the obesogenic policies and environments that we live in that predispose us to a natural outcome of being obese? Or is it both? Some combination of the two? Is it an individual responsibility, a societal responsibility, a medical responsibility? All of the above? Is obesity a disease? Would classifying it as such be helpful or harmful? I think these are some of the issues that we'll get into tonight. Look forward to that. So, without further ado, so with laying the landscape that, we're very privileged to have two national or international authorities on the issue to speak to us tonight. Dr. Arya Sharma from the University of Alberta and Dr. Jackie Zingra from Ryerson University. I'll read their bios and then we'll get to business. Dr. Arya Sharma is Professor of Medicine and Chair in Obesity Research Management at the University of Alberta in Edmonton. He's also the Clinical Co-Chair of the Alberta Health Services Obesity Program. Dr. Sharma is Founder and Scientific Director of the Canadian Obesity Network, a network of over 6,000 obesity researchers, health professionals, and other stakeholders. He's also past President of the Canadian Association of Bariatric Physicians and Surgeons. His research focuses on the evidence-based prevention and management of obesity and its complications. He's authored or co-authored more than 300 scientific articles and has lectured widely on the etiology and management of obesity and related cardiovascular disorders. Dr. Zingra is an assistant professor at Ryerson University School of Nutrition. Her research involves theoretical and experiential explorations of critical health and dietetics epistemology and what counts as knowledge in nutrition and food education and practice. Her doctoral research, a critical autoethnographic fiction on dietetic education, subjectivity, and performativity, shaped a collective understanding of food, weight, and health, and was awarded the Ted T. Aoki Prize for Outstanding Dissertation in Curriculum Studies at the University of British Columbia. Currently, Dr. Zingra serves as chair of the Center for the Advancement of the Scholarship of Teaching and Learning in the Faculty of Community Services. She serves on the steering committee of the Partnership for Dietetic Education and Practice and is a member of the Advisory Committee for Professional Affairs of the Dietitians of Canada, where she's also a registered dietitian. So please join me in welcoming our discussants this evening, and the floor will be to Dr. Sharma. Yeah, and so Jackie will go up.
All right, good evening, everyone. This is on. After that introduction by Juan, thank you so much for setting the stage. I'd like to first start by thanking all of the organizers here, especially the consulate campers, Zach, Travis, for giving me this opportunity, and it's always good to be here. I think in light of this conversation, which I've been told expressly is not supposed to be a debate, it's supposed to be sort of a friendly exchange of opinion. I thought I would set the stage by perhaps reminding ourselves that we are in Ottawa. And there's a specific significance to this because when I was doing a little bit of reading about the topic and trying to come up with what is health and what are the definitions of health, and trying to make up my own mind whether or not obesity actually is a health problem or not, I noticed that the first International Conference on Health Promotion was actually held here in Ottawa back in 1986, and there's actually an Ottawa Health Charter, or it's a charter for health promotion. And when you read the charter, there's a definition of health, and there's many dimensions of health, as you all know. And you can find a lot of different definitions of health. One of them is, and perhaps the broadest definition, is that health is the level of functional or metabolic efficiency of the body. That's what most people tend to kind of understand as health. The World Health Organization itself actually has an even broader definition, and this dates back to 1946 when they said that, or when they defined health in its broadest, perhaps, in its broadest sense as a state of complete physical, mental, and social well-being. And what's important, not merely in the absence of disease. So if you think about that, and let's break it down. Physical well-being, mental well-being, social well-being, if those are the dimensions of health that we're concerned about, then the question you really need to ask is, does obesity or excess weight affect any of those? Now, the easiest point to make here, of course, is the one when it comes to physical health. There's no question that despite the fact that it is possible to be healthy across a pretty large range of body weights. We see this even in the patients coming to our clinic who are referred there for obesity treatment. They're large. But when you do the exam, you do the test, you measure their blood pressure, you check their cholesterol, you wouldn't ask them. They're pretty healthy, and they are actually very healthy. But there's also no doubt that there's a lot of people out there for whom excess body weight is not healthy. They have consequences. It turns out that excess body fat, and I'm not sure we get to discussions about the different types of body fat. We've just heard that body fat distribution is important, so it's not just about how much fat you have, it's also important to think about where that fat is located. You can take this down to the microscopic level. You know that there's a different impact of adipose tissue, which is the technical term for fat tissue, depending on whether there's inflammation or not. The size of the fat cells we've known for a long time actually affects whether or not those cells are affecting the health. The location of the fat, all of that is important, but there's no doubt that in many people, excess body fat can affect virtually every organ system. And it's not always the same organ system. Some people get more arthritis, some people get more blood pressure increases, some people might get fatty liver disease, other people might get reflux disease, sleep apnea. We know that obesity is a risk factor for many cancers. So there's a whole bunch of different things that can happen, which are contributed to by having excess fat. Now, how much excess fat do you need to get that problem? We know that there's a big difference. Some people develop these problems with, with just a couple of pounds of extra fat, well below what you would define as being obese. And other people, as I've already mentioned, can be quite large and have none of those problems. So there's a lot of individual variation. However, we know that the risk for a lot of these conditions, and the fact that if I was just to go out and take a bunch of people with high BMI and take a bunch of people with low BMI, I'm much more likely to find many of these health conditions in the people who have higher BMI. So there's no doubt about it. That's been shown over and over again. When we look at the second dimension of health, which is mental well-being, now there's no question that in clinical practice we often see people with excess weight presenting with mental health problems, and it's often the fact, or it's often the case that some of these mental health problems might actually be contributing to weight gain, so they're not really consequences of weight gain. But on the other hand, there's also no doubt that for many people, especially those presenting in weight loss centers or people seeking weight loss, that very often we do find that their excess weight does contribute to mental health issues, whether this is just depression or it's anxiety or it's body image issues or it's not feeling well about themselves. Distorted body image is a problem. Low self-esteem can be a problem. Those are impacts that excess body fat can have, or excess body weight can have on mental health. But it's also important to understand that that some of the reason, and perhaps in most cases, the reason that there is this impact on mental health actually has more to do with social well-being, which is the third dimension of health, because anyone living with excess weight today, probably faces biases against obesity every day. The Obesity Network has done a lot of work to bring this to the attention of people across the country. We hosted the first, national council on obesity, on weight discrimination and weight bias in Ottawa just last year, because it's a huge impact, and there's no question that it is because of that societal perception about weight and obesity that's some of those consequences that express themselves in problems that obese individuals have or people who are large have in society, and this goes all the way from being bullied in the schoolyard to not finding jobs to not having the same chances in education, and certainly you can perhaps not find a job because of your size, and you might even lose your job because of your size. And those are very real things that people with excess weight actually have to face. And I'm hoping that we get into some of these discussions today. So I just wanted to set the stage that there's no question, as someone who's a clinician who sees patients in my clinic who knows the literature, that excess body weight, at least the majority of people who have a large amount of extra body weight, can certainly affect all dimensions of health that are certainly relevant to these individuals that I see in my clinic.
Fantastic turnout on such a beautiful night. Thank goodness there's no hockey on, but I hear there's basketball, so let's get going. I just want to take the liberties just for a moment. And how many of you are staring at that clock? I'm able to focus over here. That is a big clock. You've got your big clock, Aria. I want to first acknowledge the work of Dr. Linda Bacon, on whose shoulders I'm standing today, and who I would encourage you to read, if you haven't already read, her book, Health at Every Size. And so she's supporting me. Thank you, nodding heads. You are my people. It's good to know. And CIHR, and Travis, and Zach, and everyone who helped out. I have never met Dr. Sharma until tonight. But, of course, I followed your work. And I just wanted to take a moment right now to thank you from the bottom of my heart for the extraordinary effort at addressing weight stigma in Canada. I think you've done more for the movement towards fairness and equity in the work that we do around weight and obesity than anything that's happened before. And so could you all please just join me? So that was my first main important point for tonight. But we have some other things to discuss. As long as we consider obesity a disease, we promote it as an individual illness to be cured. We keep the billion-dollar diet industry alive and well, and we actually actively neglect to address the underlying social issues when you focus on a disease state. By saying obesity is a disease, we unequivocally state that fatness is something to be feared at all costs. And I do mean costs. This statement negatively affects people of all sizes in our culture, and we, as responsible, caring healthcare professionals in this room, such immense potential in this room, we need to consider doing the business of obesity differently. So let me now address the question, the first question. What are the health concerns posed by obesity? And they rest on two main assumptions. The first one being fat kills, and the second one being that fat makes you sick. So let's look at longevity first. There are about 40 peer-reviewed epidemiological studies on this topic, and all but just a handful, contradict the popular wisdom that fat kills. What most show is that people considered overweight and mildly or moderately obese live at least as long or longer than people deemed normal weight. Of course, the data are more complicated, as Arya mentioned, at the extremes of underweight and obesity. But we're talking about the large majority of people in this discussion. Some of the most comprehensive data on weight and mortality comes from government statisticians at CBC, using the data from Ann Haynes. And again, these studies, one aspect of the study, published in JAMA, found that people in the overweight category lived longer, and people who were mildly or moderately obese lived as long as those in the normal weight category. The authors acknowledged, and I quote, "This finding is consistent with other results reported in the literature." So the CDC comes up with this evidence that overweight may actually lead to living longer, and they acknowledge that others have found the same. And Raise your hand if you would expect that something important and transformative might happen because of that data, that finding. That's pretty radical stuff, but that's not what happened. So, the CDC were so, I'll use the strong word, threatened by how people responded to their findings that they almost immediately backed away from those reports. And they sent a disclaimer to health agencies and healthcare professionals like all of us in this room. Despite the recent controversy, I'm quoting, about how many deaths are related to obesity in the United States, the simple fact remains, obesity can be deadly. So, I just want to move down a little bit more quickly and talk about confounders. One thing with epidemiological studies is that they show associations, not causation. And they show us relationships. So there's an association between baldness and cardiovascular problems, but not the fact that elevated testosterone is implicated in both. So we can erroneously associate two things, but we must be very cautious about causation. And I think in this room you get that point. Let's look at fitness. Raise your hand if you've heard of the Cooper Institute. Stephen Blair. Okay, great. I'm glad to see that you're reading some of his work. They've been gathering data on a large number of patients, and their follow-up has shown that when fitness is considered, BMI is almost irrelevant, and that fat but active people, moderately active, fare much better than normal weight people who are unfit, sedentary. And Stephen Blair likes to say, I was a short, fat, bald man when I started running, but after running nearly every day for 30 years and covering about 70,000 miles, I'm still short, fat, and bald. And a man, all that. So Stephen Blair's work was pivotal for me starting out, and that work's been around for a long, long time. Again, would you expect a radical transformation in practice based on that work alone? Orientation towards fatness? No, you would not. Stigma discrimination, Arya has touched on. My goal is to talk about not only obesity itself, but the war on obesity. And the war on obesity or fatness has probably made us fatter, that's the big irony, than we would have been otherwise. That's my contentious statement. It's well established that dieting for weight loss, so trying to intentionally lose weight, is a predictor of weight gain, and has been shown in 7, not a lot, more work needs to be done, but it has been shown in 7 studies that have been examined on this issue. And so whether we consider longevity or disease, it is evident that fat, as I like to call it, or obesity, is exaggerated as a health risk.
So each discussant will have about 1 minute to respond to each other, so you can be preparing your questions. And I will ask that when you do have a question, that you come to the microphone, identify yourself and your orientation, you know, sort of where you work, what your context that you're coming from, and try and keep your questions fairly succinct.
So just a quick couple of responses. The first one, I think the so-called survival paradox, which is something that I've actually done quite a bit of work on. I've published several papers on that was just alluded to, is actually real. When you look at data, epidemiological data, the skinny folks die first, always. Until you actually get to a BMI of about 30 or even 35, you don't really start seeing a risk. And the problem with that is not because obesity is not a risk factor, but I think because we're measuring the wrong thing. We're measuring BMI, which really doesn't tell you anything about anybody in terms of risk factor. And I think we'll come back to that discussion about whether BMI should even be used as a definition of obesity, especially, and I'm very strong in this, it's not a clinical diagnostic tool. We should not be diagnosing obesity based on BMI. Now, it was alluded to the Cooper study. Now, Cooper is one of the Steve Blair, who worked at the Cooper Clinic, is actually a co-author on one of the papers that we've done, which very nicely demonstrates that when you take the Cooper Clinic data, yes, BMI does not predict death. What does predict death, however, is whether excess weight is affecting your health or not. When you look at people who have health problems because of their excess weight, those are the people who are high risk to them. And as a clinician, I can tell you that is the problem with BMI. BMI does not help me find people who decide who's sick and who's not sick. I need to, fortunately or unfortunately, need more information on it to decide that, which is why this becomes a clinical diagnosis and not something that you can just measure by getting on the scale. So I'll just make those 2 points. There's other things that I'm sure we'll get into the discussion. But I do want to make the point that BMI is a crappy definition in the clinical context. We should stop using it and stop basing medical decisions on it. And the second point is that I totally agree that one does have to look at how weight is actually affecting health in order to make decisions on whether somebody needs to lose weight or not.
Was it to put chairs up on the stage and have the camera pointing right there and I'm wearing a dress? I think we're going to need to check this video out before it actually goes anywhere public. That was your idea, Travis? Zach is so red right now. I'm sure it had nothing to do with it. Look how red it is. Wow, it's getting redder. Okay.
Go Aria!
One thing I've learned tonight, always wear pants to a debate.
A discussion.
A discussion, a dialogue. I'd like to point out something actually about Mark's slide. He mentioned the dialogue, the national dialogue on healthy weights. And the number one vote getter on the public side, because there were different aspects, was that we need to stop talking about weight. And I happen to know that because Julie Rochefort was the champion. Oh, Julie! She had some fans in the crowd. Julie Rochefort was a graduate student who was working with me, or was in a classroom with me, when she took that up as an issue. And she's right on. And again, I spoke to this at the beginning. One thing that, as soon as we start talking about obesity as a disease, fatness as a disease, fatness does harm, we stigmatize fatness. And we medicalize it and we pathologize it. So the efforts to reduce weight stigma are thwarted when we continue to position fatness in that way. And I'm thrilled to hear Arya say that we should not be using BMI anymore. I agree, concur, all dietitians in the room, reevaluate. There are other outcome measures.
Okay, thank you. So the floor is open, and remember, at this point in the evening, we're talking about health impact of obesity. To try and contain your enthusiasm for talking about obesity as a disease for the last segment. But if there are any comments or questions with respect to the health impact of obesity, the comments made by the panelists, if it is a question, please direct it to one or both of the candidates. If it's a comment, that's okay too. Don't be shy. Travis, you want to put 10 minutes up there?
I'm certainly not shy. So I might as well kick things off. It's the only free puff. I've been friends with Arya for a long time, and Jackie and I have even had some occasion to collaborate over the years. And I think that all of us would agree, and Arya's mentioned it, and Jackie's mentioned it, that using BMI as a measure is really useless as far as describing whether or not we need to have treatment, and also whether or not obesity is a disease, and we'll leave that for later. I guess when you're talking about data like the CDC data, if you're going to bring it up, I think it's also fair then to bring up the fact that if we look at the data that PACE tends to use most regularly, which is Flegel's data, I think it would be fair to say that Flegel's data is the data that is most accepted. Even when you account for the benefit of being overweight, I think it's still, and I could be off by a few thousand, but I think it's still around 25,000 deaths a year that Flegel's data would still suggest are directly attributable to obesity. And I guess what I'm wondering is not whether or not there's risk. I think that there is quite clearly in my practice. I see it on a daily basis. But what about those 25,000 people on an annual basis? True, they may be the people who are the body mass indices of 35 and above, who knows? But that was my understanding of the best case scenario for Flegel's data, and maybe I'm mistaken, and you can help me with that.
So yes, Flegel's data challenged that the number 300,000.
I know.
So we're down from 300,000 to 25,000, which, I mean, how do you position that as good, bad, or otherwise? It just is. I have to read you something here, Yoni, from another bloggist. Bloggerita, blog diva. Her name's Reagan Chastain. Has anyone read the blog Dances with Fat? Okay, great, okay. So, and your 25,000, your question reminds me of her blog statement. When news headlines ask readers, are we doing enough about obesity? I want to respond with, are we shaming fat people enough? Are we ostracizing fat people enough? Are we oppressing? Are doctors doing a good enough job of ignoring fat people's actual health issues and instead of focusing on their body sizes? Are we making fat people feel horrible enough? Are we stereotyping? Are we doing a good enough job of conflating weight and health? The answer always seems to be no, we could be doing more. If we had a viable treatment that didn't have any long-term consequences, then I would say let's keep focusing on helping those 25,000 lose weight. Lose how much weight? Maybe we should give him a lapel mic.
It's okay.
He's going to
I mean, once upon a time we didn't have a treatment that was viable for diabetes either, but ignoring it as a problem probably wouldn't have been a good idea.
That's quite true.
That's all. I'm not disagreeing with you.
I
think
know.
stigma is awful and a huge problem. I think you know that I think that way. But I just think that, you know, if we're going to talk about things, I think cherry-picking data is bad for both sides. And I think both sides would tend to do that on a regular basis.
Of course, we're human beings, and
But I do think
use our
personally, as
science.
a physician, 25,000 deaths a year is not something to just completely write off as being inconsequential to the question of what do we do. And if we don't label it as an actual condition that warrants study, well, then that's just going to continue.
There's many conditions there are many things that warrant study that aren't labeled as conditions. So because of our own passion as scientists, we study things because we're interested, we're curious individuals. What I think we should do, and I'll elaborate on this more, and it's written quite eloquently by Linda and others, is health at every size, promoting health regardless of what people weigh. As long as we focus on weight, so that means that we help everyone else who's dying for other reasons other than those 25,000, which is a number and associations and so on that we could debate. But we help everybody of all healths, of all weights, be healthier through a variety of things, of means. Eating healthy, being active, according to, you all know this. So that's what we do.
Respond in terms of diabetes, and when we did have great treatments, I think it was also very important that we did no harm with whatever intervention.
I don't think either of us would disagree on that.
Right? Yeah.
So please use the mic so that people at the back can hear the discussion.
Just watching our intervention.
I think, so I'll just repeat it. So it's just that we shouldn't do any harm, and that when we didn't have a treatment for diabetes, we didn't try to do harm. I think there's huge work to be done on preventing harm in the treatment of obesity. Huge work. But I think that we need to work on that, and not stop.
So I work at the Center for Healthy Active Living at GEO, and so I want to go back to the key definition of health, because one of those things is the stigma, right? And is that an issue in the person, or is that an issue in the rest of us? Because if we took that out, and I would argue, if we took that out, we'd also treat the mental health piece of all these kids. If we could do that and actually focus on that and health at every size, we may actually impact, again, the physical health as well, because these kids would be more willing to get out and do things, right? So I think, I just wonder, it's like saying, we're up north, there's an epidemic of frostbite on our ears. Is that because there's something wrong with us, or because it's damn cold outside? So it kind of seems like the same sort of thing, and we might be barking up the wrong tree by focusing on the physical part and sort of assuming that, well, these poor kids have low self-esteem as well, and maybe we need to be looking at ourselves instead and looking at what our problem is with it instead.
I was waiting for that. So here's the thing. I'm a simple medical doctor, which means that if I was practicing up north, and the person with frostbite walks into my office and says, you know what, I think my ear is falling off and turned black and blue. Can you help me? I would look at that. I would actually say, yeah, that is an injury, and an injury, by the way, can be, is a health condition, and it is a disease if you want, and needs treatment. And I think the rationale that I'm hearing here is that just because we don't have that are we going to define diseases based on whether or not we have treatments or not? Because then I can think of a lot of conditions for which we don't have treatments, where we can probably agree they're diseases, but because we don't have a treatment, well, we're not going to call them diseases. So we find a treatment that's safe and that doesn't cause harm. I think in a lot of questions, and I'm going to put this in the next segment, I'm going to say I think actually we are doing harm by not medicalizing obesity. And we are increasing bias and discrimination by not medicalizing obesity. But that's going to be the next statement.
One last thing. One thing I didn't mention when Yoni mentioned his question was that issues of morality. And I think that's a little bit of what you're saying when we examine our own biases and beliefs. Raise your hand if you've read the book by Gardner Wright, The Obesity Epidemic. It's a very important book. Okay, so I counted 1.5 hands. Gardner Wright quoted in the book, "Science on obesity has more to do with preconceived moral and ideological beliefs about fatness than a sober assessment about existing evidence. It speaks to our cultural assumptions about bodies, about fat, about whether we think it's right or wrong, whether we're being good citizens, and the vigor with which we want to help the poor fat people become thin." I think it's a moral issue.
I just want to follow up on that question, I guess just about stigma. I recently went to a mental health talk, and they were talking, and for them it was mental health might be one of the sort of last stigmas, and we just need to get the word out there, like Belle, their Olympian, talking about, let's talk about mental health. But yet we see the stigma still with obesity, as you guys are mentioning. And obesity, we talk about a lot. There's lots of talk going on. I heard a research done last year saying that parents are more willing to talk to their children about sex than they are about weight. When sex used to be taboo, and now we're saying that weight is more taboo than that. So my question is talking's great, but how do we do it so that we're helping and not harming?
Well, I'm pleased to hear that you're thinking about how we talk about weight. And I don't want anyone to go away from this evening thinking that we should be doing nothing. We should be abandoning any efforts to help people of all sizes be healthy. And that we shouldn't talk about weight because it's taboo. That's a very common misperception. We need to talk about all aspects of a person if we want to address health. The health promotion says that health is holistic. And so yes, how we talk about weight, there's a lot of great resources from the Blood Center who participated in the summit on discrimination around fat and size, weight bias. We talk about it in ways that people want to talk about it. We engage in respectful dialogue about all kinds of things, sleep patterns, eating patterns, activity patterns, relationship patterns, stress patterns, and how those things may be affecting someone's weight. So instead of leading with weight, why do you think you're overweight? Or what do you think would help you become a normal weight? Those are very stigmatizing kinds of conversations. talk about people's lives in a way that you can get clues about what might be leading them to be unhealthy or not. And there are lots of great suggestions around you, so when you go for coffee and have a sandwich, open that question up for others to share.
Okay, thank you. It's becoming increasingly common in the healthy active living conference world and so on to give pretty regular standing ovations to people, in part to reduce our sedentary behavior. So I'm going to suggest that after each third of these that we give our discussants a standing ovation before we start the next section. So that brings to a close this section, so please join me. Okay, so we'll move on to the medicalization of obesity. Dr. Sharma.
This one is, kind of straightforward. I mean, I already mentioned, I think by not medicalizing obesity, we're actually doing a huge disservice to people who have obesity. And I think in the third segment, we'll probably be discussing how to define obesity, because we've already all agreed in the room that defining obesity on the basis of BMI is not a good idea. But here's the problem. I went to medical school. I'm a medical doctor. They didn't teach me much about obesity, and looking back, if obesity is not a medical problem, well, then they were right not to teach me about obesity. In fact, actually, we still don't teach medical doctors about obesity. Most of our health professionals don't actually get a lot of training in obesity management. They may get told that it's not good for you, but we don't actually spend any time teaching about obesity. Well, if obesity is not a medical problem, then I guess that's fine. I mean, then doctors don't need to learn about obesity because it's not a medical problem. It's not a health problem. There's nothing to medicalize. Doctors have gotten way enough real health problems to worry about, like people with diabetes and people with heart disease and people with osteoarthritis and sleep apnea. Well, those are real medical problems. Let's not get doctors involved in worrying about obesity because that's not a medical problem. It's not medicalizing. In fact, if it's not a medical problem, I don't see why healthcare systems should be worrying about obesity at all. Why should we be paying for treatments? Why should we be providing public access to bariatric surgery? Like, it's not a medical problem. It's you. Then go to Mexico, get it out of your pocket. I don't care. Actually, in fact, if the only reason you're in my office today is because of your weight, well, then you should be here. Please leave, lose weight, do whatever you want. Come back when you have a real medical problem, because I'm a medical doctor. I'm here for medical problems, not for lifestyle, whatever you might call it. So what's the patient going to do? Well, I can't go to my doctor because he tells me it's not a medical problem. I got aches and pains, and I don't feel good about myself, and I've got all these actual issues, and I read about it, and I know that it's my excess weight that's killing me, or just making my life very difficult. Where do I go? Well, it's not a medical problem, so obviously I can't go to a medical or a health professional. Where do I go? Well, go to the internet. Find all those crazy supplements that, of course, Health Canada doesn't need to regulate because it's Health Canada. We don't regulate stuff that's for lifestyle and whatnot. Who cares? We don't. We don't see this as our job to stop people from selling, wacky, crazy devices that you can use to tone your butt. I don't care. That's not really a medical problem at all. So, the healthcare system is not going to pay for obesity treatment. Obesity is not a disease. It's not a medical problem. You want your stomach stapled because you want to look better, well, go to Mexico. Hey. We are also telling people indirectly, you know what? It's not our problem. Your excess weight, whether it's affecting your health or not, is really not our problem, because that is not a medical problem. It's a, maybe it's a self-esteem problem, maybe it's a lifestyle problem, whatever it is. And when I listen to all the public health guys, they tell me, it's so simple. All you need to do is, eat a couple of veggies, walk around the block. You don't have to have this problem at all. And the fact that you have it is actually your fault, and that's why, just imagine, we medicalize obesity, and now we have the taxpayer paying for evidence-based obesity management in clinical practice. And I can actually now go to my doctor can bill for seeing me because of my obesity. The health system will actually pay for treatments for my obesity. That meeting with the dietitian where I sit down and she actually starts looking and reviewing my diet and starts talking about how I could possibly reduce my caloric intake. Well, that doesn't get paid for because, well, that's not a medical condition, right? So she's a health professional. That's what her training is. That's what the healthcare system pays. So I think we're actually stigmatizing and making it very difficult, and it's very unfair. And why would we not medicalize obesity when it affects your health? When we medicalize every other condition that affects your health? Why would we not pay a health professional who's licensed, a regulated health professional, and allow him or her to bill for that service, provided in a setting that is regulated? Why do we throw people who are suffering from obesity, and I'm talking about the people who are suffering from obesity, I'm not talking about anybody who wants to lose weight, to the dogs? When we talk about the weight loss industry, we're not talking about a profession that is regulated. We're not talking about people who are providing science-based treatments. We're not talking about anything. We're talking about people who are in it for the money. I think it's unfair to obese people who have obesity as a health condition that we are exposing them to health professionals who don't think they need to learn about obesity because, hey, it's not a medical condition. It's not a condition I can bill for. Why are we not looking at obesity as a health condition, medicalizing it in the way, and providing that access in the healthcare system, in the medical system, like we do for other conditions that affect people's health? I think not medicalizing obesity is discrimination. Never mind whether your obesity is because of genetics or it's an endocrine problem, maybe it's a binge eating disorder, maybe it's your medications that are doing it. Never mind that your weight is causing your diabetes, your arthritis, your fatty liver disease, your sleep apnea. Never mind you can't work in your job, maybe you can't find a job, doesn't matter, you can't get down the floor, play with your kids. Never mind that there are, in fact, actually evidence-based treatments for obesity. These actually do exist. Well, never mind all of that, because really, you know what? You're just fat. Come back when you have a real medical problem, because I'm a medical doctor. I'm here to treat medical problems. Don't waste my time with stuff that are not medical problems. In fact, because obesity is not a medical problem, I don't get paid to do the tests. I don't care. I don't get paid to find out whether you have any of these binge eating problems. It's not my issue. I don't need to spend any time at all counseling you about your weight. Why? Because your weight, your excess weight is not a medical problem. And while we're at, I have a few more other conditions which I think we need to demedicalize. We need to start with depression and addictions. I do not think we need to medicalize depression and addictions. Well, what's depression like? These are unhappy people. Come on, go get a life, right? Addictions, you know what? Just stop using. It's not good for you. We know that. Why don't they just stop? Why are we medicalizing heart disease, blood pressure? When did that ever become a disease? I mean, aren't these just lazy people eating too much salt and not moving enough? Stop medicalizing high blood pressure. Maybe diabetes. We need to stop medicalizing diabetes, actually. How about we stop medicalizing prostate? How about we stop medicalizing prostate cancer? My last point here, because I just read that screening people for prostate cancer is a problem because almost everybody at a certain age has cancer cells in their prostate. These cells almost never kill them. We need to stop medicalizing prostate cancer. Lots of things I can think of we need to stop medicalizing. Why stop at obesity? Simply because they're just fat guys? If you shame and blame them enough, maybe they'll lose weight. Maybe that's the approach we need to take. I think it's high time we medicalize obesity.
I thought I entered an alternate universe here to hear Dr. Sharma say we should stop medicalizing. And I thought that's what I was arguing. I agree with you. I'm trying to keep this straight in my head. We need healthcare professionals, and I'm not going to limit this to physicians or dietitians or nurses or OTs or PTs. We need healthcare professionals to stop harming people because they think they're helping them. There are many conversations that are taking place because people have not been trained, not only about obesity, and again, I use that word very carefully because I have some issues with it, because it has a certain connotation. It's a pathologizing, it's a medicalizing word. I mean, that's the whole point. We do not prepare people on how to talk about the poor associations between weight and health. People have been talking about weight loss as a way to be healthier for far too long without the proper training, and we should stop it, just like you said. people need to be trained better on how to approach these conversations. There are a lot of myths driving the idea that medicalizing obesity will be helpful. And one of the myths is that we actually have evidence that weight loss prolongs life. And we don't. We do not have conclusive evidence of this. And when the National Institute of Health convened a conference to review the scientific literature, they concluded most studies in the strongest science shows weight loss is actually strongly associated with increased risk of death. So this is the NIH. Now, the intensity with which we want to help those 25,000 people who presumably it has been demonstrated that their fatness is causing them problems, speaks again to the moral association we bring to fatness, that it is somehow wrong or abhorrent and we have to do away with it. And yet when we hold this view, whether we're health professionals or not, we're actually encouraging people to try to lose weight in a way that could actually lead to weight gain. So the biochemistry of discrimination is something that I want to speak about here. Everybody's heard about the biochemistry of stress, where when you're feeling stressed, your cortisol levels go up. And you may be unable to regulate your appetite and hunger. And you may become insulin resistant over time, and a bunch of other factors. Your neuropeptides become dysregulated, you become antithermogenic. You begin to not focus on certain unnecessary things, but whether you're going to survive. Cortisol causes that. Well, consider the cortisol levels that are raised when someone tries over and over and over again to lose weight because our cultural assumption says it's unhealthy. And they keep not being able to comply with a very well-intentioned advice that we think is going to make them healthier. And so over time, the cortisol levels go up and we become antithermogenic, we can't regulate our hunger cues, and we have selective adipose tissue increasing. And we know what that causes. It's not good. Insulin resistance, cardiovascular disease, inflammation. And so we see here that our efforts to do good are actually causing the opposite effect. And so that's what I want people to think about, is that when, regardless of whether we believe obesity should be medicalized or whether obesity disease, if we keep proceeding the way we are, we're actually making the problem worse. And so we have to look at another way. And what's really difficult about this is about resisting the medicalization of obesity, because it puts in only certain people's hands the ability to solve the problem. And the way that I believe we need to solve the problem is by stop talking about weight as a problem. Stop talking about fatness as a problem. And start talking about health and the ways that we can become healthier again at any size. It's very difficult for people who have held onto a belief for so long to let go of that belief. And one of those reasons is because of something called obesity epidemic entrepreneurs. Raise your hand if you've heard this. Where did you hear about that one?
Where did I hear about
Yeah.
that? I read the same blogs you read.
That's fine. So, Lee Monahan is a sociologist, and he published a paper in 2010 in Body and Society that presented a typology of obesity epidemic entrepreneurs. And that is those who actively make fatness, or obesity, a correctable health problem. As long as obesity maintains its status as a correctable health problem, there's a business to be had. I think Ara summed it up pretty well. We can bill for that. You heard that, right? So are you one of these 6 obesity epidemic entrepreneurs? Are you a creator? Do you pose the scientific facts related to fatness and how fatness is very damaging? Are you a moralizer? Do you work in the media to report those facts and to propagate those facts and to generate the moral panic that is associated with fatness? Are you a legitimator? Do you work in the government? Do you establish policy that has BMI surveillance happening in schools with children because it's for their own good? I like that. We don't listen to the paper. We might listen to the bell. Are you a slimmer of dieters? Lee Monhan is from the UK, so he likes this word slimmer. He's a dieter, or are you a slimmer? Do you display the moral worth of having a slim, slender, fit body as a way to sell products, sell gym memberships, sell? So I'll just leave you with that question about obesity and epidemic entrepreneurship.
So let's talk about the entrepreneurship business, because I think if there's one thing that the weight loss industry fears the most, it is the medicalization of obesity. Because the minute we medicalize obesity, and we medicalize and we define that the fact that weight loss is a treatment for a medical condition, that entire complex now has to be regulated. But I cannot open up a store over here and say, I'm offering complimentary treatment for breast cancer. We're supposed to be done in 2 minutes, right? I cannot open up shop as somebody who's been, I'm now your diabetes advisor because I took a weekend course where they told me that here's this new supplement that I need to now push on everybody who walks through the door who has diabetes. And I'm going to call myself as the diabetes clinic, and I'm going to make all these claims about how this supplement is going to cure your diabetes. And in fact, I'm going to just have this given to people who've taken a week on certificate. They're certified diabetes consultants. We were closing down in a second. I think the fact that we're not medicalizing obesity is exactly what opens the entire field to these charlatans, what do you call them, the snake oil, sellers, and all of that. Because, why? Because we're not medicalizing it. And I think we are continuing to do a disservice to people who have what I consider a very serious condition when your obesity is affecting your health, to not be able to walk into your doctor's office and get the kind of help that you need, like anybody could get if they had diabetes, if they had heart disease, if they had cancer, if they had whatever. They can go to the health profession and not just get qualified help, but they will get qualified help that is paid for by the public healthcare system. And in order to be able to advocate for access to obesity treatments in the public healthcare system, we need to medicalize obesity. There is no other option. Otherwise, the people that you're talking about, the entrepreneurs, we are leaving it just to them.
Okay, the other myth I'd like to mention is about the war on obesity's cost. And a lot of people say that we need to reduce obesity because of the cost for taxpayers who are paying for increased health issues with increased levels of fatness. And there's no denying that there's some data to show that people with higher BMIs have higher health costs, absolutely, than thin people. But when you look closely at that and you examine the assumptions underlying it, there's really some false accounting that's going on with these data. Raise your hand if you've heard of BMI profiling. We're in the same box. BMI profiling suggests that healthcare professionals selectively perform more tests, which cost more money, on people with higher BMI or fatter people. Because we're not talking BMI anymore, so I can totally liberate it and just leave it out of my discourse. So whether or not their genetics, health, diets, or lifestyle justify it, people who are fatter are experiencing BMI profiling, which is leading them to cost more money to the healthcare system. So we need to examine some underlying fundamental assumptions. There's the other aspect of weight cycling that we haven't talked about that happens. And weight cycling can happen whether you're going on Jenny Craig, Weight Watchers, whether you have a stomach stapling, or whether you're doing some kind of snake oil thing. I heard recently that if you smell, there's a vial of vomit that you can smell to turn you off food. Have you heard of this one? I wish I hadn't heard of it. Some things you don't need to know. So what happens when people are weight cycling is that they're losing and regaining, and it puts an inordinate amount of stress on the body, which could help people diet their way up to some of the sizes that we're seeing, that Ara is seeing in his clinic and others. And so how is the solution actually making the problem worse?
Thank you. Questions, comments from the audience?
Yeah, it's okay. My question maybe is directly to Dr. Sharma, regardless in regard to what you said. But in the introduction, we were shown how, I guess, 3 layers of government, federal, provincial, and municipal, are all focusing on obesity and are all focusing on interventions and whatnot programs towards this problem. Well, how will medicalizing the term or calling it a disease make any more difference if all of the government is already so focused on fixing the obesity problem, yet me as a dietitian, I am still not, covered to help someone with obesity? How will saying obesity is a disease, how will that change if all the government is already saying, woohoo, let's take down obesity?
Because they're not medicalizing it. They are turning obesity into a lifestyle thing where we take the pop machines out of school and we slap a tax onto this, and we do our measurements, and we can just get everybody running around the schoolyard. Nobody has a right to be fat, and the fat guys who are still fat because of, despite all of those efforts that we have now put behind this, well, then they're just stupid. I think it's not medicalizing this. I would much rather see the government not worry about that. Take a health at every size approach. Do what they do to increase physical activity and healthy self-esteem and whatnot for all the kids. Don't worry about what their rates are. Not make that fair. But for those kids who do have childhood obesity, they need to come to see you, and you need to get paid for seeing them. But that will not happen if obesity is not medicalized.
Yeah, hi. My name is Sina Miasari. I work for CIHR. And actually, it's not a comment or a question. It's more like a disagreement that I would like to express regarding a statement that Dr. Gingras actually made. It's when you mentioned that there is no evidence available regarding the relationship between being fit and living longer. I think the evidence is great out there in the literature, from the cellular model, animal model, to human model. And I think being fit or losing weight not only increases the lifespan, but the quality of life. And I think we might want to talk about the quality rather than the longevity.
I was worried there for a moment that I misspoke, because being active is very beneficial to quality of life and longevity. In fact, there is a difference between being fit and being active. And I think a lot of people in this room would be able to help me define that. But Stephen Blair showed that you don't have to be fit necessarily, you just have to be moderately active to demonstrate the benefits to your health. But I think you got that message, and you said that if you're fit, you will automatically lose weight, or if you're moderately active, is that?
Well, maybe
Say it again.
It's a terminology issue because when we talk about fitness, well, I automatically refer to a good cardiovascular metabolic kind of activity, which implies that you're an active person. I'm not talking about being skinny. I'm not referring to that at all, but fitness for me is having a, whatever, VO2 max, which is reasonably acceptable. It's being active for me. So being fit is a good chance to make you live longer than being fat or obese. So I think it's like a terminology kind of, misuse. Yeah.
My question to you is, can a person be fit and fat?
Yeah.
So we have no issues.
But you were saying that there is no evidence. Maybe I'm misunderstood. But what were you referring to when you said that there is no evidence that fit people live longer?
No, I didn't say that.
Okay.
I said that moderately active people, regardless of their size, are living longer than unfit, normal weight people.
But you referred to some evidence lacking in the literature, so maybe I just kind of jump on that without probably kind of analyzing what you were saying. But there is evidence.
Absolutely.
Yeah.
Absolutely.
So I think we're on the same page.
Yes.
Thanks.
We are on the same page. Have people heard, just while I'm up here, have people heard about the National Weight Control Registry? Yes, okay. So a list of people who have lost weight over 30 pounds and have kept it off for at least a year. So with the success of dieting, we would think that this number would be very high if dieting is so successful, if weight loss, promoting weight loss for health is so successful. But in actual fact, there is a very small number of people on that registry. And once your name is on it, you can't get off if you've regained the weight. It's very difficult. And to maintain your success, you have to be eating about 1,200 calories a day, weighing yourself every day, exercising for 60 to 90 minutes every day. That's what the people who are on the list report doing. Is that healthy? People come to eating disorder clinic saying those exact same things and they're diagnosed with an eating disorder, weight preoccupation, exercise obsession. So we have to be very careful of what the National Weight Control Registry is calling successful.
Okay, I am José Bertrand and I'm from the Ottawa Hospital. I just want to, first of all, the congratulations for the organizer to have Jackie Gingras and Dr. Sharma, because both of you really advocate both sides of the obesity. And I think tonight it really gave us a really good overview of really both the challenge. So you really kind of paint the whole picture. I just want to bring and comment on both sides. I definitely, working in pediatric surgery now, this is the new coming and the really popular kind of era. And I agree with Dr. Sharma saying that when you have patients that are 40, 50, and 70, 700 pounds, you really talk about a different obesity. So I think Jackie is talking about a certain type of population, and Dr. Sharma is really talking about the other extreme. So if you think about the continuum of eating disorder and obesity, this is exactly what we have right now that they try to paint for us. I definitely agree with Jackie that if we still continue to have all kinds of people treating the obesity, but how also painting that for our kids, I think we definitely cause harm. Because working in a pediatric surgery clinic, you see all those patients over and over again that diet, and the diet unfortunately causes a lot of harm. On the other side, when you see an obese patient, morbidly obese, 400, 500, that doesn't have the appropriate care through the, I will say along the road. So definitely they will develop obesity, they will develop sleep apnea, and they need the expert. But the bottom line I really want to think, make that audience think about, some people, and I really thank the comments that was done, that, when you have an eating disorder, usually you're not focusing on the weight. You're focusing on the whole person, the whole health. And most of the time, it starts in your head. Obesity is exactly the same. That's why it's kind of nice to have those two people, because it's really start to, in how you feel in your head, that will maybe trigger all the physiological aspect and maybe lead, unfortunately, to really chronic obesity if they didn't really kind of have the healthy start. But some of those patients, you have to realize, we're talking about apple and oranges. Some have genetically kind of a problem that need to have medical treatment. So I definitely agree with Dr. Sharma and the other initiative, and I don't know if you're aware, but the 5A that is just going on right now. What is the 5A? Is really all the advocacy to really train the medical field, saying when you have a patient that is obese in front of you, which kind of question it relates to Crystal, my student, by the way, that I'm really proud of, that is dietitian right now, but meaning that we need, I think tonight, we advocate for both different populations, and that's why I find it's great. But at the same time, we have to remember that people are suffering. After they have a bariatric surgery, they definitely also, and you understand, have a different life. Is it for everyone? No, and that's why we need to prevent that people think that now bariatric surgery will be the name tag. So I just want to maybe, Dr. Sharma, if you can explain more, what is the 5A and this whole promotion regarding that?
Well, thank you for that comment. I'm going to give 3 very quick responses. I'll get back to the 5A's in a second. The first one is, I was not just talking about very large patients, because I think one of the mistakes that we also do in obesity management very often is that we think it's always the large person who has the problem. What we have learned is that there are a lot of people who don't meet the BMI criteria for obesity who have health problems related to excess weight, because it completely depends on where that fat is located. If I were to put on 2 additional pounds, and all of those 2 additional pounds would go right here, my blood pressure would be up, my risk for heart disease would be up, and my risk for diabetes would go up. And I would be far away from what you would consider obese, but there would be no doubt that it is those 2 additional kilos of weight that I'm now carrying in some other done that are causing those problems. And so I think we need to not only abandon BMI, start looking at severe obesity as the people who need bariatric surgery. I also think that that the surgeons are probably operating on too many people, because I think they're also doing operations on people who probably would fit the Edmonton obesity stage criteria 0 or 1, where I would say their risk is actually so low that despite the fact that they're pretty large, those are not the guys we would recommend surgery for. There might well be smaller people for whom surgery is probably adequate. But now, having said that, getting back to the 5A's, those of you who haven't heard about them, the 5A's is a program which is really designed for primary care, with the help of primary care practitioners, consisting of a 5-step program in dealing with obesity practice. And the first A is asking for permission to even talk about it. So when I have a patient in front of me who's presenting with excess weight, I don't just assume that it's a health problem. I don't assume that it's a problem for that patient. I don't assume that that patient is ready to do anything about it. I'm also not going to make any assumptions about whether that excess weight is actually affecting that person's health. But in order to be able to start a dialogue and find out whether this person is even sees this as a problem, whether now is the right time to do it, I need to be respectful of that and do the ask. Once I've done the ask, I do the assessment. I don't give advice before I've done an assessment. Once I've done the assessment, I give the advice. But then the key part is that we come to an agreement. And this is going to be the most challenging part of the 5A's. For the health practitioner to come to an agreement on what do we do. Because I can tell you, patients all want to lose weight and they want to lose a lot of weight. My job as a clinician very often consists in telling patients, well, you know what, you actually don't have to lose weight. For the kind of weight that you're trying to lose, it's not a weight problem you're trying to solve, it's a body image problem. No amount of weight loss is going to solve the body image problem.
Just a final comment?
Yeah, sure. So I just want to echo what Arya had said in terms of until we actually medicalize obesity, I do think we're going to see stigma continue in society, because until it's medicalized, it's a disease of the individual. We've chosen to do this. We've made ourselves this way. It is gluttony, it is sloth, it is laziness, and I don't see that changing without medicalization. I am surprised, though, Jackie, just that you chose to medicalize the people who were in the National Weight Control Registry. So I have patients in the registry. I'm quite certain that if you asked them if they felt like they had eating disorders, they'd say no. There's around 7,000 people in the registry now. The average person's lost 67 pounds, kept it off for more than 5.5 years. you know, I'm not saying that they're all healthy people, but at the same time, I don't think it's appropriate to medicalize them as having an eating disorder. That's it.
All right, time for a standing ovation. Now on to whether or not obesity should be seen as a disease, and we've kind of been creeping down that road already. Dr. Sharma.
Okay, so again, I was just looking at what are diseases. So when you look at the term disease, you know, any condition that impairs normal function or affects health, you know, can be referred to as a disease. When you look at the disease literature, we normally have two types of diseases. We have communicable diseases, which are diseases that you can catch. Those are largely infectious diseases. And then we have this very large group of non-communicable diseases. These are diseases that you can't catch from the person you're sitting next to, or you can't catch this on the bus. It's not a bus. It's not a bug that's flying around. Now let's look at the conditions that we consider to be non-communicable diseases. These can be genetic conditions. These can be endocrine problems. These can be malnutrition. These can be mental health problems. These can be cancers. When we look at some of the drivers of these non-communicable diseases, it could be as simple as excessive exposure to sunlight if you have the wrong skin type. Environmental toxins, occupational hazards can cause diseases. Accidents and injuries can be considered non-communicable diseases. The list goes on and on and on and on and on. Well, I can think of all of these reasons as being reasons that can cause weight gain in an individual, and that in that individual can then affect that person's health. So if I just use those criteria, there is no question for me whatsoever that obesity very clearly falls into that non-communicable category. Now, I would be very confident about this except for one thing, and that is that there might be a small minority of obese individuals for whom it actually may be a communicable condition. How many of you have heard of the obesity virus? It's not it's not a fantasy. That virus exists. We know exact structure. We know exactly what the virus does. We know how this virus, when it infects animal models and human adipocytes, will actually cause them to expand and do it. People used to think that ulcers, gastric ulcers, was a problem of people smoking too much and having too much acidity. Now we know it's a bacteria that causes it. So I'm not going to be at all surprised if in 10 years from now we recognize that a big driver of the obesity epidemic is in fact infection. Maybe it's environmental toxins. Maybe it's something else. And what I want to put to you is that in our debate of obesity, I think one of the problems that has been apparent in all of our discussions here is that we are not actually defining what obesity is. We are all falling back into defining obesity as a certain BMI cutoff, which I think is a fundamental flaw in how we define this. If you use a very different definition of obesity, when we talk about obesity as the accumulation of excess body fat that threatens or affects your health, it becomes a health condition. And that is what we're talking about here. That is what we're debating. There's no debate whatsoever that you can have excess body weight or you can just be large and be perfectly healthy. And in fact, a lot of our own research has actually shown that even at a BMI of 40, which is quite a lot. I mean, you're 100 pounds excess weight. It does not mean you have to be sick. It does not even mean you're going to die early. It doesn't mean anything. Right? And on the other hand, there are people with BMIs of 27 who, because of their excess weight, at a BMI of 27, have diabetes, have sleep apnea, have fatty liver disease, have reflux disease, have problems. Which of these two people has obesity? Right? So I think the problem that we have in this entire discussion about whether obesity is a disease or a medical condition is not the discussion whether obesity, is a health risk. It's also not a discussion whether when obesity is a health risk, does this require professional treatment. And I disagree that there's no evidence that intentional weight loss can prolong your life. The best evidence comes from bariatric surgery, in fact. We published a paper on 10,000 people showing that people who intentionally lose weight over 5 years, high-risk patients, with or without pharmacotherapy, actually have a very significant reduction in their mortality risk. I think a lot of the confusion comes, and we've heard the data presented, is that we're not looking at intentional weight loss in these studies where we see that people who are losing weight are dying first. Well, of course they're losing weight because they're sick and that's why they're dying. Right? So we have to be very careful. Now, we don't have a lot of good data on intentional weight loss. Why? Because it's just so difficult to do. Nobody can do intentional weight loss in the long term with just diet and exercise, or not enough numbers can do it so that we can follow them long enough to see that it saves lives. I have no doubt it will probably save lives, but only those people who actually have what I call obesity, and that is excess weight that is actually affecting their health.
So just to get back to the National Weight Control Registry for a moment, and my point in bringing that up is not to stigmatize, but to ask the question, do people feel pressure to remain on the registry once they are there? They're representing the people who can do it, who did it. Are they going to extraordinary means? And I don't know the answer to these questions, but I want to put that out there as a viable question to ask. Are people on the registry going to extraordinary means to remain on the registry? And are there harms associated with those extraordinary means? So again, I can't answer those questions, but I'm thankful to Yanni for prompting me to ask those questions. Now let's take the person with the BMI of 27. And let's think about all those associated issues, diabetes, heart disease, and so on, that come along with that person, that one example. Again, people can have a BMI of 27 and not have any other associated conditions. How many people think that increasing that person's activity would result in an improvement in those conditions of diabetes and cardiovascular disease? Just raise your hands. Okay. So how many people think that improved nutritional habits could result in some improvements in the conditions as well? Yeah, okay. Weight does not have to change. In fact, weight may go up. Not BMI, but actual weight may go up. And if we use weight as a measure of success, again, not BMI, just weight, and a person's weight goes up, and how many people have encountered this in clinical practice? Where a person is eating healthier, and they're more active, and their weight is going up for many different reasons. Maybe it's increased muscle mass, whatever it might be, and they stop those behaviors because the weight is going up. That's a problem. Fatness, obesity is already medicalized. Let's face it. We don't need the government to allow people to start billing for certain services to reduce weight, to not already know that obesity is medicalized. From a different perspective, now you understand that we're coming from different perspectives here. I'm a health sociologist in a lot of ways. Yes, I've been trained as a dietitian in the biomedical model, but I'm a sociologist. I like to understand what influences our behavior. Arya is a self-described simple medical doctor, and I don't know what word is simple, but again, coming from different perspectives. So from a sociological perspective, obesity is a medicalized term. It arises from a medicalized discourse. And raise your hands if you've heard about the word healthism, if you've heard the word healthism. Okay, I like this. So, many of you have heard that. I wish I'd heard about it sooner in my career. Healthism states that the individual is solely responsible for making the change to their health, and that there are very few outside causes that will help that individual. So with medicalization of fatness or whatever, we have a very slippery slope to healthism, which says that you're negating the social influences on behavior. I have some A's to share with you too. There are only 4. There's not 5. There's 4. You remind me of those when you ask that question. I've worked with the 4 A's for a long time. before people can change their behavior, and before people can change their behavior long term, they need to come to an awareness of what their behaviors are. They need to acknowledge, and I'll use weight as an example since this is the topic, they need to acknowledge that what they weigh is what they weigh. I'm fat, and I can, the third A, accept that. That doesn't mean that I don't want to change my health, but I'm fat, I'm whatever weight I am, and I'm going to accept that right now. And then they jump to action. Eating healthier, getting more sleep, coping with stress in different ways other than alcohol, gambling, shopping, eating, drinking, whatever it might be. And then the action, the tone of the action is different when it comes from awareness of the issues, some acknowledgement of this is my weight right now, today, and some acceptance that trying to lose weight may not be beneficial in the long run, may make things work, may make me stressed, and then taking action from that point that actually leads to healthful behaviors. If people are jumping straight to action, again in this example, changing their body weight to fit cultural norms, then the action is going to fail. 95% of the time, we've heard that number bandied about lots. And so we need to prepare people in such a way, and do this diligently and comprehensively in medical schools, in dietetics and nursing, so that they're able to support people where they're at. And I think the first A in the Obesity Network's 5 A's is asking permission. It also is absolutely necessary to make sure people have informed consent. So if I am going to start this program, what are the possible benefits? What are the possible consequences, the negative outcomes that I could face if I'm going to start taking this drug, or if I'm going to start focusing on eating less calories, focusing on caloric content. And so that's what I want to offer to you, is that there's a new way, health at every size, to look at these issues that doesn't focus on weight. It's shifting the focus away from weight to health. And what it does encourage is accepting and respecting a diversity of body shapes and sizes, expanding our notion of what is acceptable in terms of body weight and body size. Eating in a flexible manner, this is really hard, it sounds simple, but it's really hard. Eating in a way that responds to internal hunger cues. Eating when we're hungry and stopping when we're satisfied, not full. How hard is that these days? The obesogenic environment makes it very difficult. And then finding joy in moving one's body, not for the caloric binging that happens when I exercise, but for the way I feel qualitatively that will keep me exercising long into my life. And it will be a long, happy life for most people if they're exercising. So I'll leave it at that.
Yeah, I thought this was going to be 11, but here's the last point that we really do disagree, and in fact very strongly. So the first one, I think, apologies for this, but this was almost embarrassing in the way that you were portraying obesity and all of obesity as essentially a behavior, which I think does a disservice to a lot of the patients that I see. I see some of the people that I've met in my life who have the healthiest diets that I've ever seen, who do the most amount of physical activity, and I tell all my patients, if you can lift 300 pounds out of that chair and carry it across the room, you're already an athlete. Don't worry, right? Because I can do that. So I think by reducing obesity, and remember, we're talking about the medical definition of obesity here, that is excess weight that is affecting your health, to simply a matter of changing your behaviors, or maybe simply a matter of accepting the way you are. You're big and you do have your health problems. Well, you know what? That's too bad. Maybe if you just eat a little bit healthier, get more sleep, and feel better about yourself, you'll be perfectly fine. That'll be okay. Sleep. There's also benefits of using a CPAP machine when you go to sleep, because you do feel refreshed in the morning afterwards. And never mind that there's a million studies showing that if you actually lost 20 pounds, that you wouldn't need the machine. Forget about that. just accept the way you are and the way that you're made and feel happy. You know, find some other thing in your life that you can build your self-esteem on. This is ridiculous. I mean, I'd be booed out of my office. I'd be faced with slamming doors for my patients who walk out in a huff saying, this guy must be crazy. You know, think of all of the reasons that people can gain excess weight. Medications, genetics, what happens to you in utero, what your mom ate before she became pregnant that you might affect your weight today. That's how complicated these things get. Start thinking about environmental toxins. Start thinking about, and simply thinking, well, all fat people are the same because all fat people are just eating unhealthy and need to move more, and they need to accept how big they are, and they need to really come to a point in their lives where they're ready to make and change those behaviors. And if they can change those behaviors, they're just going to be so healthy, happy, fat people, and that's really where we need to get to. Rubbish.
Why does it take the last segment to get things really fired up? Now we're getting into it. We're going to have to extend this. The acceptance piece of the 4As is commonly misunderstood. And I hear it again in Ara's response. That it's all about giving in, giving up, feeling good, peace, you know, it's all good, love one another. That is highly oversimplifying the complexity of health. What I'm saying is that if you're focusing on losing weight to feel good about yourself, and I actually heard Ari say this earlier, then this isn't, what I'm saying is if you're focusing on losing weight to accept yourself, then, and you're not accepting yourself because you're not successful at losing weight, then perhaps it's time to attempt a different approach.
And that's not obesity. That is not a medical feature of obesity. Having excess fat and not being able to accept yourself because you have excess weight is not a medical definition of obesity.
Yes, and having excess fat is not culturally acceptable. And so you're conflating cultural definitions of what is acceptable with medical definitions. If people are coming to you because they have health issues, and you said this yourself, you don't have to offer them a weight loss solution to solve the health issues.
When weight is what is causing the problem.
And the only problem with that is that there are high numbers of negative consequences to those solutions to the weight problems.
Yeah, when they're not at this space, not because of the pressure, but
well, there are 2 people in this room who do it the right way. We need to help other people promote health. And what I'm saying is that we absolutely do not need to medicalize it. We're not giving up on health. We're not asking people to give up on themselves. We're asking people to reconsider, including healthcare professionals, the way we're going about this weight issue in a way that is meaningful, ethical, and responsive to the evidence we now have.
Thank you. Okay. Do you want to give us like 8 minutes, Travis? Is obesity a disease? Anyone care to comment?
Just a quick question. Obesity, as defined, the way obesity is defined today, based on BMI cutoffs.
yeah, that's not obesity.
Right,
These
right.
laws are fine obesity.
Exactly. So how do we change the definition of obesity so that everybody sort of understands what it really is when we're medicalizing? If we're going to medicalize, how do we get people to understand?
If I have a good answer for that, it would be very simple. I think there is a value to BMI as a screening tool. When you do population studies, when I want to know are people in Ottawa getting larger or less larger, is the prevalence of obesity going up or down? If I can get the BMIs of people in Ottawa, that will tell me that. Well, that is a very different situation from making the diagnosis of obesity, 278, ICD-9 code. In a patient in front of me where I have to make the decision, is this person going to have a medical and a health benefit from better managing their weight, which may or may not include weight loss, okay? Prevention of weight gain is weight management. That is a very, very different question. And I think that is where we have to come up with a solution. And sometimes this is why we need to medicalize it, because I need 6 years of medical school, and perhaps more, to have an obese patient in front of me, to know exactly what tests I need to be doing, what questions I need to be asking. I need to know the biophysiology of weight regulation. I need to understand the psychosociology of this patient that might be contributing to the problem here. I need to be able to understand and interpret and order the right tests for this patient in order for me to actually decide whether this is somebody who I would say, you know what, don't worry about your weight, go home, be happy, or you are someone who really needs to start worrying about your weight because your weight is going to kill you, because here are all the problems that you have. Here are the treatments that I can offer, and we're going to have a discussion about that. I need 6 years of medical school and specialist training in order to be able to do that. I think every health professional needs that kind of training.
I'd like to thank Dr. Hajnakas for asking that question. I wonder though how you could medicalize, I have another question, but before that I wonder how you could go through the process of medicalizing something that we don't have a proper definition for.
Well, let's start with mental health. Mental health is a very good example, because in mental health, we have problems around definitions. Nobody's going to argue that depression is a medical problem, that it's a health problem. When you look at the actual definition of depression, how do you diagnose it? Well, what is the ultimate diagnosis of depression? It is an experienced psychiatrist who does a standardized assessment and makes that diagnosis. And that's what they go to medical school for and psychiatrist school for and get trained as a health professional. It's not some guy who's taking a weekend course who's staying in some strip mall trying to sell you a supplement. Right? That is why you need to medicalize obesity. That is why obesity has to be a medical diagnosis. It is only a licensed health practitioner with the experience and the training who can make that diagnosis and to say, you have a weight problem, you have got obesity, you need to lose weight. Another person who might be twice the size of the first person says, you know what, you've got excess body fat, don't worry about it, you're as healthy as you're going to get.
Mental health is a good comparison, but it is, I understand what I understand of mental health. It is much more difficult because what one person experiences for depression might be different from another, same with anxiety and whatnot. So it just seems to me that
obesity is the same.
Would be
Obesity is the same. I've got two people that got exact same amount of excess body fat. One has got health problems. The other person says, I don't know why I'm here. My wife told me to come. Right? It's exactly the same problem. The excess weight is a health problem for the one person. It's not a health problem for the next one. Now, who makes that judgment call? It's going to be between me and the patient. And that's why you need to medicalize it, because this diagnosis cannot be made by somebody who's throwing out numbers somewhere. If you've gone to medical school, if you've gone to dietitian school, if you're a trained, licensed, regulated health professional, it's your business to make that diagnosis, and you are the only person who should be allowed to treat that condition.
I wanted to, and then just to comment about your acceptance. I think that accepting, even if obesity was medicalized, acceptance is big for any disease. To first be able to accept that this is who I am now, and so therefore now I have to seek help. But that was just my comment. So anyways, but the larger and whole comments that I can get off the way, because there's a lot of people behind me, is that you both are saying this, like, you both are saying the same thing, that you're anti sort of BMI, you're pro-HAES, not all fat people are unhealthy. It's funny though, just because you both have different perceived paths of getting there. We know there are other determinants to obesity. Some of them have been mentioned. I think this guy in the blue shirt did a presentation for a symposium. Who talked about not sleeping enough, calcium, and environmental factors. So tell me exactly, because I'm on the fence, I don't know if it's a disease or not, but what exactly would the sequelae of events be if obesity were to be medicalized? Would we, would we be having better training? Would we be researching into medical pollutants? Would we be telling people to stop watching TV?
I think exactly that's what's going to happen. The minute you medicalize it, it becomes a diagnosis, and I cannot get a license to be a medical doctor without actually showing my competency in diagnosing and treating and managing obesity. I will fail medical school. I will not get my medical license to practice medicine in this country if I cannot pass an OSCE on obesity. Then we will have the trained professionals, right? Because I'm not talking about weight loss. I'm not talking about the healthy obese people needing to. I'm not talking about population approaches. I'm not talking about whether we should all be sleeping more or whether we should be doing something about environmental toxic. Those are different stories. For me, as a medical doctor working as a medical professional, I expect to receive the training, the resources, and the support that I need in order to treat what I think is a condition that is impacting my patient's health. And in order to be able to do that in the healthcare system, using taxpayers' dollars in a public healthcare system, I expect the government to be giving me those supports. That will only happen when you medicalize obesity. And I agree we need a different definition, but we've got to come to that definition. As long as we look at this as individuals, people's choices, behaviors, lifestyle, whatever, we're not going to get that kind of approach, which I think people who have obesity deserve.
So these will be the final 3 speakers. No one else come up. Please try and get to your point.
Hi, my name is Eric, and I don't think obesity is a disease. But I do think it could be medicalized, and that's a different story. Right. If obesity was such a bad thing, don't you think we'd have, over evolution, acquired something to defend against it? In fact, I do think, like an immune system against obesity, it's actually a very good thing to be able to store fat quickly and efficiently. And there's actually no mechanisms in place to protect us against this. There's 2. The first one is a very sluggish increase in energy expenditure, which will never overcome the rate of eating. The second is predatory failure, and there's very little of that nowadays. On the other side of the spectrum, what you have is basically a freaking Christmas tree that lights up every time you try to cut back on the calories. So you're in a situation where you cannot treat this condition. You know why? Because you're trying to treat something that's not broken. And that's what I have to say.
So yeah, it's a great question. The reason that we all have the ability, or most of us have the ability to become obese, is because we have actually been selected for that property, which doesn't make this a natural condition, right? I mean, you could have the same argument to say that, part of why we are having, other chronic diseases because people are getting older. We are all not designed to live to the age of 100.
Yeah, but you can treat heart disease without counter-regulation, right?
It's not true. You can't treat blood pressure without counter-regulation, which is why monotherapy for blood regulation normally doesn't get you anywhere, which is why we're now using combinations of 2 and 3 and 4 drugs, which when you stop the blood pressure always goes back up. That does not make high blood pressure a normal state. And you can't say we have not been selected to be hypertensive. The complexity of the system is what is making it so difficult to treat, which does not mean that when this system is doing what we don't actually want it to do, that is a natural state of health. Because then we shouldn't be treating hypertension and we shouldn't be treating a lot of conditions that are difficult to treat. And again, coming back to the argument, just because we don't have a treatment, which by the way we do, does not make this, doesn't mean we shouldn't be medicalizing it.
Hi, I'm Sally, and I'm here representing patients with obesity. So you can clearly tell my bias now. I would say that I've been suffering from obesity for 30 years, and I've never had a doctor bring it up. Of course, they've addressed it when I've brought it up, but when I have, they've never had the training. They've had the willingness to help, but they've never had the training to do that. If medicalizing it could possibly help us get more training for our doctors, so they would know where to send me, and then possibly, ideally, would be certified, legitimate help would be paid for by the medical system. Amazing. But otherwise, even if my extended healthcare insurance would cover it because it was a legitimate disease, I would love that. It would be great. And I do think there are systems out there to treat it, and I think a lot of people in this room are doing a lot of that work, and thank you.
I just want to share my own experience with understanding obesity, and I think everybody understands that depending where you come from, what kind of training you received when you were a trainee. For example, in my case, I did my PhD in the animal model. So for me, obesity was a rat that weighed 400 grams. That was obesity for me, and I published studies on that, and that was it. The first time I really opened my horizons to obesity in humans was in Kananaskis, when Dr. Sharma presented cases where individuals were maybe 500 pounds overweight, and they had to be lifted with some device. The bed they sleep on can't get in from the normal door in a hospital room. So I was kind of shocked to realize that I didn't have a good understanding of what is obesity. And why I am telling you this is because I want to come to the 4A, especially the second one when it comes to action. If you're an individual that cannot even go to a doctor's office, then how can you take action and start self-treating obesity, but just accepting it and taking action? In some cases, you need to lose weight before even realizing what's going on. That's just a point that I wanted to share with you. Thank you.
Thank you. The fourth day is action, not the second. But anyway, it's on good. How many people here think obesity is already medicalized? Just raise your hands. Okay. But not enough, Art says. What I think we're also both asking for is better training. I don't believe medicalization will lead to better training. In fact, I think medicalization will lead to better training for a small number of people who benefit from the medicalization of obesity. And as long as you're benefiting from something and you're advocating for the continuance of that thing, then you're in what's called a conflict of interest. And so it's bias to how that thing is ever going to possibly change, because it'll affect your livelihood. So I think what we're both asking for is better training. We all need better training, regardless of where we're coming from. But what's really important is that that training be done from evidence-based practice. And I don't think that training should be in the hands of a few highly specialized individuals. We need to know how to refer appropriately, but we also need to how to destigmatize weight and fat. And so that we are talking about ways for people to be healthy that are effective long-term. I just want to leave you with one last point. There's a learning curve to getting to changing your paradigms, and whether that's learning to brush your teeth in the morning or learning to promote a health at every size philosophy. It's difficult. That's our role as a healthcare professional, is to keep learning. You can develop skills with people to help them start to trust their inner cues, to help them eat appropriately, the right amounts of food at the right times of the day. You can help people start to be active regardless of what size they are. We have to broaden our thinking about what kind of activity is possible. So that requires some imagination on our parts, even if they are 500 pounds, like they say. There is clear evidence that this kind of approach is learnable and teachable. And so the leaders in our fields need to advocate for better education. And I hope that some of you will take on some of that role as well by advocating for work that you know needs to be done in healthcare practice. Thank you very much.
So I just want to come back from philosophy to medical science and talk about some of the issues here. I think we need to demedicalize cancer. I don't know if you people know this. There's actually oncologists out there who are doctors who make a living treating cancer. There's a lot of drug companies who make a lot of money making compounds that are used for treating cancer. You won't believe this. There's actually a whole CIHR institute that does nothing else than fund the research of a whole bunch of people who spend their life researching cancer. I think if we demedicalize cancer, then all of these people will go and actually find something sensible to do for their living. So I don't buy the argument that just because there are going to be doctors making a living treating obesity, that is a reason not to have those doctors who know that to treat obesity. I agree, actually I disagree that they should be specialists. Obesity is far too common a condition to actually have specialists. I think this is fundamental training for every health. If you are practicing as a health professional today, you need to be an obesity specialist. Everybody needs to be. You know, when you're talking about a condition that's affecting 1 in 4, 1 in 5 Canadians, we cannot have specialists doing this. This is part and parcel the business of the family doctor, of the community dietitian, of everybody else who's out there doing that. I'm not in favor of specialists. Let's save the specialists for the 500-pound cases, right? But we need to treat everybody. Unfortunately, that's not going to happen. If this is not a medical problem, you know what? I'm a medical doctor. Don't waste my time with stuff that's not medicine.
Standing ovation. Create a little room between the two my back's turned. Okay, just to wrap up, so the initial survey that we had, and so we have a pretty good split here. 44% said yes to the question, is obesity a disease? 44% said yes. 39%, almost exactly the same, probably not statistically significantly different, said no, and 17% were undecided. What I want to know, and this doesn't disclose which way you said, how many people, as a result of the discussion today, would likely change their vote? Just a show of hands, and this doesn't mean you're a yes, no, or maybe. So there are a few, maybe half a dozen, something like that. Okay, interesting. So anyways, that brings our session to a close. I want to make 2 reminders. The evaluation form is on your table. Please fill it out, and they do what with it, Travis?
You can give it to one of us or leave it on the table on your way out.
Okay. So you fill it out, turn it over so no one sees your answers, and why don't you bring them up to Travis's table if you could? That would be great. There's still refreshments at the back, tea and coffee and so forth. Our panelists, pugilists, panelists are here, and I'm sure they'd be happy to discuss things further with you. Zach, do we?
One question. Just because we're here and I see so many of you in the room, can all the boot campers, all years, and I think I counted 11 of them, can we have a group photo taken? So don't leave before we have that group photo taken. Not now, but just don't walk away, okay? Because 11 from, I think, all 6 years, so it's pretty good.
Thank you very much for everybody for being here. I hope you enjoyed today's discourse. It was friendly discourse, so that was always very nice. This obviously wouldn't be possible if Travis and I got singled out, but of course the whole U Ottawa Consniff group for their contribution and planning. So Angela Alberga, Joseph Abdulner, Richard LaRose, JP Chaput, and Megan Carter for the coordination and organization of this event. So they deserve it. And of course, we can't do this without funding, so CIHR for their support for the Cafe Scientific, a guest speaker grant from the Canadian Obesity Network, and kind support from HALO from the Children's Hospital of Eastern Ontario. And last but not least, I will do it in no particular order, but to Mark Tremblay, Ari Sharma, and Jackie Gindra for a very engaging evening. We have a small gift of appreciation for you. So thanks again. And that concludes the evening. Have a great night.